Hello again. This will be a summary of shock states and sepsis. So, what is the definition of shock? It's a clinical condition that results in cellular hypoperfusion. And although shock states have different causes and different presentations, they all share some similar features, and that is hypoperfusion, hypercoagulability, and activation of the inflammatory response. In hyperperfused states, as we have already seen, there's a lack of sufficient oxygen, which causes the cells to convert to anaerobic metabolism. So in a shock state, we have imbalance between oxygen consumption and delivery, or what we have already established, imbalance between oxygen demand and supply. Because of that imbalance, the cells turn to anaerobic metabolism, which produces lactic acid as a byproduct, and that leads to metabolic acidosis. If oxygen continues to be insufficient to meet the cellular needs, the cells will die. So shock is believed to progress through three increasingly severe stages, and that is compensatory, progressive, and refractory stage. I would refer you back to your textbook and table 14.1 on page 299. So please do go over the regular PowerPoint presentation because you will have far more detailed information. But in the compensatory state, what happens is that the body is trying to maintain circulatory volume, blood pressure, and cardiac output. So the sympathetic nervous system will kick in, and because of increased heart rate, the blood pressure initially may still be normal. Heart rate will have to increase. Respirations will go up because we need to get more oxygen into the body. And you remember in the emergency how the sympathetic nervous system shifts the blood from the periphery to the core organs, the heart, the brain, the lungs. So your skin will become cold and clammy. Kidneys will receive less urine and less blood and produce less urine, so the urine output decreases, less blood flow and oxygenation to the brain, causing changes in mentation from little restlessness, agitation to confusion, obtundation, and so on. And if we look at AC balance, you will see respiratory alkalosis initially because why? The patient is blowing off a lot of CO2. If we don't intervene, especially with elderly patients because they have more difficult time adjusting to these changes, the person or the patient will slip into a progressive state. The progressive state is characterized by further complications in the circulatory and metabolic system, and the inflammatory and immune responses become fully activated. Now, the body is unable to compensate anymore, right? Because of increased heart rate, the cardiac output will decrease, which will lead, because the filling time is reduced, so the systolic blood pressure will drop below 90. We need to be careful of mean arterial pressure, and that will go below 65, which is dangerous, meaning there is not enough perfusion and oxygenation of the cells. The heart rate will continue to increase, the respirations will be high, and initially, And as the inflammatory response kicks in, the chemical mediators will be released, like histamine, causing blood vessels to become more permeable. The fluid will shift into third space. That will be evident in your lungs, where you may hear crackles and increased now CO2 above 45 because the patient is tired, he's unable to breathe fast anymore, so the respirations actually go down and the lungs begin to fill up with fluids. The skin is now more mottled with petechiae over the body and because of vasoconstriction. I forgot to mention that, remember, renin-angiotensin system will also kick in when kidneys receive less blood. Renin is released, it goes to the liver, it activates release of angiotensin 1. Angiotensin 1 goes to the lungs, where it's converted with the help of angiotensin converting enzyme into angiotensin 2, which is now a very potent vasoconstrictor. So you will have extremely constricted vessels. So the afterload will increase, but the preload has decreased because of fluid shift and fluid leak from the third space. Less and less blood is getting to the brain, so patient is becoming more lethargic. And if we are looking at acid-base balance, we will notice metabolic acidosis. And in the final irreversible stage, the cellular and tissue injuries are so severe that a patient's life is not sustainable, even if metabolic, circulatory, and inflammatory complications are corrected. This is a full-blown multi-system organ dysfunction syndrome, and in spite of all interventions, there is severe hypotension and hypoperfusion of the organs. That's your refractory stage. Next, so what are the risk factors for shock? Well, let's look and be logical. You lose fluid in case of bleeding, you're hypovolemic. Do you have enough oxygen, enough carrying capacity of your red blood cells, hemoglobin, to carry it to the cells? Probably not. In terms of trauma, again, you may have external, internal bleed. In terms of burns, you have again fluid shift, not enough in intravascular space to carry oxygen to the cells. We already talked about MIs, infection, definitely, and disruption of sympathetic tone, like in neurogenic shock or allergic reaction. So the goal of treating patients in shock is to reestablish adequate organ perfusion and oxygenation. Some of the nursing interventions, again, discussed more in detail in my regular PowerPoint, but would be number one, let's see what the cause is, and then make sure that the patient is stable in terms of fluids and oxygen. We will be giving fluids based on his hemodynamic status. You're checking blood pressure, you're checking pulses, you're checking O2 saturation, you're drawing labs to see what is his carrying capacity, his H&H, basic metabolic panel, it should be BMP. But you also want to know, because under shock, there is also that coagulation factor that is activated. So the patient may be producing a lot of little tiny clots that are clogging up the microcirculation, further interfering with oxygen delivery to the cells. So you want to know the PT, INR, PTT, what are the ABGs? And definitely because of decreased mentation, you always want to promote safety and maintain constant communication with the patient and family. Some of the medications that we will give in treating shock states would be in these three categories: vasoconstrictors, dilators, and inotropes. And we will go over that in class and see which ones increase the heart rate, increase oxygen consumption, which ones are maybe used as a first-line medications, and so on. Now we look at septicemia and septic shock. This is a new definition, and it says that septic shock, actually sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So septic shock really occurs as a result of the complex interaction among invading microorganisms and the immune system, the inflammatory system, and the coagulation system. And I think that is very well represented on this slide. You have activation of chemical mediators like histamine causing a vascular leak. That also helps immune system cells like monocytes and macrophages and phagocytes to get out of the vascular system and to the site of attacking bacterial attack. Then we have activation of the coagulation system with plugging of capillaries by not only white blood cells, but also by aggregating platelets and fibrin, which further interferes with oxygen delivery to the system. So these pro-inflammatory cytokines, in addition to that, stimulate the release of nitric oxide and resulting in widespread vasodilation. And then you have in pulmonary system, inflammatory mediators such as neutrophils cause capillary leakage into the pulmonary interstitium, resulting in, again, interstitial edema. In hematologic system, pro-inflammatory cytokines activate the coagulation system. So it's a pretty big mess. In order to quickly react before the patient goes into a progressive state, because these stages apply to patients in septic shock just like they did with patients in cardiogenic shock. So we use this Q-SOFA quick assessment for these three elements. Is the mentation, Glasgow Coma Scale less than 15, the respiratory rate greater than 22, blood pressure less than 100, the patient is potentially septic. But we do need to look at these other parameters that I have listed. We have also moved faster to treating these patients to 1 hour bundle versus a 3-hour bundle that we used to rely on before. First, we're going to basically use evidence-based practice guidelines. We are assessing patient we're assessing patient and drawing labs to check the lactated level and procalcitonin, which increases lactated level with anaerobic metabolism, procalcitonin with bacterial infection. We're going to obtain blood cultures before we give antibiotics, before we need to know what the causative agent is, and then empirically we'll bring broad spectrum antibiotics. Please make sure that we're checking oxygen because the patient may need, oxygen supplements via a mask or a nasal cannula or even a vent. Fluid resuscitation is usually started at 30 mL per kilogram of crystalloids. That's your osmotic, now I'm getting stumped, D5W or a normal saline. We're giving vasopressors, and sometimes we have to give steroids because if there is a lot of inflammation and fluid leakage into third space, steroids help stabilize the cell membrane and reverse that fluid shift. Blood transfusion may be necessary if hemoglobin is less than 7, but you can check with your hospital. If all of this fails, the multiple organ dysfunction syndrome will occur. Okay, we'll talk more about all of this in class, but for right now, this is just a quick focus on the essential things you need to know about shock states and sepsis. Thank you.